Welcome back, focused learners, to the Explainer. Now, our goal today is pretty simple, but definitely ambitious. We're going to completely conquer the complex world of neuropharmacology, and we're specifically zeroing in on anxiolytic and hypnotic drugs. I know learning this stuff is hard. It can be a real headache, but I'll be breaking down the concepts, drawing all the right connections, and throwing in plenty of mnemonics to make sure this actually sticks in your brain. So, go ahead and turn on your English subtitles, buckle up, and let's decode this central nervous system together. So here's our roadmap for today's session. We'll kick things off by introducing our main protagonist, the confused neuron. Then we'll define the actual symptoms and unpack our pharmacological arsenal. After that, we'll dive really deep into the GABA mechanism, highlight some absolutely crucial side effects, and finally, tie the whole shebang together with a practical, clinical treatment algorithm. All right, let's jump right into our first chapter and start building that foundation. Chapter 1, The Confused Neuron. Charles Dickens famously wrote, "It was the winter of despair." And let's be totally honest here, nothing induces an acute anxiety attack quite like studying neuropharmacology, right? It can literally feel like a winter of despair. But don't worry, stick with me. We are going to take these incredibly dense textbook concepts and turn them into high-yield, easy-to-remember pearls. So we have to start with a really foundational question. What actually happens when a neuron gets confused? Think about a hyperactive network in the brain, when your neurons are just firing on all cylinders without any clear reason or external trigger. Well, this brings us directly into the pathophysiology of anxiety and sleep disorders. And that leads us perfectly into our next topic, which is symptoms and disease classification. Because obviously we need to clearly define the problem before we can just start throwing medications at it. Let's get our definition straight, and I really want to highlight the difference here. Anxiety is this unpleasant state of tension, apprehension, or uneasiness. It's basically a fear that arises from either a known or a completely unknown source. Now contrast that with hypnosis, which is artificially produced sleep. The absolutely crucial difference here? Calming someone down and taking away their tension is an anxiolytic action, but knocking them out into a state of drowsiness, that is a hypnotic action. They're on the exact same spectrum, but they are entirely different endpoints.
To really visualize this, think about what anxiety actually physically feels like. Your sympathetic nervous system goes into overdrive. That's your fight-or-flight response. Imagine you are literally running from a hungry tiger. You've got tachycardia. You're sweating, trembling, feeling palpitations. Now flip that. The parasympathetic system is your rest and digest mode. When a patient is dealing with severe, debilitating anxiety, their body is permanently stuck running from that tiger. So we use pharmacology to basically force the body back into that rest and digest state.
Now that we know what a confused hyperactive neuron does to the body, let's transition over to Chapter 3, Classification of Calming Drugs. Let's officially open up the medicine cabinet.
Here is our pharmacological arsenal. First up, we've got the heavy hitters, benzodiazepams, like diazepam and alprazolam. Second are the older barbiturates, like phenobarbital. Third, the non-benzodiazepine hypnotics. These are usually called the Z-drugs. And hey, a super easy mnemonic for you here. Z-drugs help you catch some Z's. Simple, right? And finally, we have other anxiolytics like buspirone. You'll definitely notice a historical shift in clinical practice here, where benzos have pretty much entirely replaced barbiturates. We're going to see exactly why in just a second.
But how do these drugs actually work down at the cellular level? It is time for Chapter 4, Mechanism of Action, and we're focusing on our brain's great inhibitor, GABA.
Let's walk through this magical little sequence step by step. Step 1, GABA binds directly to its receptor. Step 2, the central chloride channel opens up. Step 3, all that negative chloride rushes in. And Step 4, hyperpolarization happens. Basically, when a positive neuron gets flooded with negative chloride ions, it just shuts down. We are literally putting the brakes on the brain. And listen, here is your massive high-yield pearl for exams. Benzodiazepines increase the frequency of this channel opening, so think frenzos for frequency. Barbiturates increase the duration of the opening, so think barbiturates for duration. Lock those in.
Of course, just like in life, there are no perfect solutions in medicine, only trade-offs. Let's move to Chapter 5, Side Effects and Contraindications. We really have to respect the raw power of these medications.
When you go in and artificially inhibit the entire nervous system, well, you're going to get some very predictable side effects. We're talking daytime drowsiness and ataxia. And ataxia means absolutely zero driving, period.
We also see cognitive impairment, and at high doses, dangerous respiratory depression. Also, keep the liver in mind. You have to use these super cautiously in patients with hepatic disease. Think of it like a tired, overworked liver trying to process these heavy drugs. And here is a massive flashing warning sign. You never ever mix these with alcohol. The synergistic depression of the central nervous system is no joke. It can be fatal.
So let's look a bit closer at why clinical practice shifted the way it did. Benzodiazepines are generally much safer. And crucially, if a patient accidentally overdoses on them, we actually have a reversal agent. Flumazenil, it's a lifesaver. But look at barbiturates. They aggressively suppress REM sleep. They induce liver enzymes, which basically ruins the effectiveness of any other medications the patient is taking. They have horrific withdrawal profiles. And worst of all, they have no antidote. None. So yeah, benzos simply offer a vastly superior safety profile.
All right, the most important part of all of this is the application. How do we actually use this knowledge in the real world? Let's transition to our final chapter, the pharmacotherapeutic treatment algorithm.
Let's map the specific drug to the specific clinical scenario. For acute agitation, your absolute go-to is lorazepam. Why? Because it has incredibly rapid anxiolytic properties. It is perfect for an emergency setting. Next up, elderly anxiety. The preferred drug here is buspirone. This is super high yield because it doesn't cause sedation or ataxia, which is critical for preventing fatal falls in older patients. Finally, for insomnia, we reach for our Z drugs, like zolpidem. They act fast, they have a nice short half-life, and they aren't going to leave your patient with a massive, groggy hangover the next morning.
So have you learned your lesson like Mark Twain's cat on the hot stove? You know the story, right? The cat sits on a hot stove once, pulls away, and then never sits on any stove again. But in neuropharmacology, the brain is incredibly adaptable. If you artificially depress it with these calming drugs for too long, it doesn't just pull away, it actively fights back by downregulating its own GABA receptors, and that is exactly what leads to tolerance and severe withdrawal. So the ultimate clinical question for you to take away today is this: how are you going to use this pharmacological algorithm to calm a confused neuron without accidentally creating a brand new dependency? Something to think about. Keep studying hard, stay curious, and I'll see you in the next explainer.